To everyone joining our webinar today, a very warm welcome from all of us at the Oxford India Centre for Sustainable Development. I'm Vinita Govindrajan, the administrator of the centre. We are joined today by our very distinguished speaker, Mr. Keshav Desiraju, former Secretary of Health and Family Welfare to the Government of India. Our moderator for today is Dr. Anant, Jani, who is Oxford India Centre's Research Associate and Honorary Research Fellow at the Department of Primary Healthcare Sciences at the University of Oxford. Our webinar will begin with a presentation by Mr. Desiraju, followed by a discussion with our moderator and then a Q&A with the audience. Please note that the webinar is being recorded and will be posted online soon after. Thank you again for joining us. Over to you, Anant.
Thanks very much, Vinita, and welcome to everyone joining this webinar on a very important topic. India having a population of over 1.3 billion. Obviously, India's response to this crisis is extremely important from a global perspective, and there's probably nobody better or more well-suited to speak about this from a very broad and holistic perspective than Mr. Keshav Desiraju. So as Vinita mentioned, he's the former Secretary of Health for India. And he's also, I have two props here. He's published this book. I'm not getting paid for this advertisement, by the way, called Healers or Predators, which is a book about that he and some of his colleagues edited on healthcare corruption in India. And being a fairly prolific writer, he also has a book coming up on this in a completely different sort of category on MS Subbulakshmi, who was a Carnatic classic Indian musician that should be coming out from HarperCollins in August or September. So as Vinita mentioned, Keshav is going to do a presentation and then we'll have a moderated discussion and then we'll open up for questions from the audience. So please ask questions using the Q&A function and then we will answer these questions during the open Q&A session. Keshav, over to you.
Thank you, Anant. Thank you, Vinita. It's very good of you to have asked me, and I'm happy to be doing this. The subject of the evening is somber, but I think there are some interesting things that we can say. Could you have the next slide, Vinita? Vinita, the next slide. Yes. Now, the first thing I'd like to point out is that the entire discussion on COVID-19 seems to be conducted in terms of numbers. The numbers are important, but they don't tell you everything. And there are some, when the dust settles, when the virus is gone, I'm sure there'll be a lot of work for epidemiologists to do, for data to be analyzed as to why it is that the spread has been so uneven across the world. And in India, as you can see from the numbers before you, the number of cases has just crossed 100,000, and the number of deaths, this was yesterday's figure, 3,303. Now, it's always messy getting into a discussion of, you know, is this a better or a worse figure than other countries? Any death is a death, but the numbers comparatively are still on the lower side. Those of you who have been following this would know that the Americas and Europe have been much more severely affected as compared to East Asia, Southeast Asia, the Eastern Mediterranean regions. Now, and within India too, the state-wise differences are quite marked, with Maharashtra, Gujarat, Tamil Nadu, Rajasthan, and for some peculiar reason, the newly created Union Territory of Ladakh having the highest number of cases. Now, very quickly, because this is going to become a big issue in the months to come, you know, when people begin talking about how quickly did countries respond. India's first case was on 30th January, a student returning to Kerala from Wuhan. It was on 24th of January that the Chinese report first came out in the Lancet. Though our first case was 30th January, the pandemic was declared by WHO on the 11th of March. and India's first lockdown happened on the 25th of March. Now, there's one other important date here which I have not put on the slide, but following India's first case on the 30th of June, on the 4th of February, the National Disaster Management Agency wrote to all states, alerting them to the impending disaster. In fact, a letter which makes very, very good and important points, urging immediate action. It's not very clear why enough action was not taken on that letter. And as I said, this is something we'll have to come back to later on. When the government of India got off the ground very quickly, the NDMA right into all states, nothing seems to have happened significantly till well into March when the first lockdown was declared. Now, another statistic which has been thrown about, which you can see at the bottom of the slide, is that even as of now, the number of deaths per million significantly lower in India than in many other countries. The implications of this and why this is so are things that we will need to study again in the future. The next slide, please, Vinita. Now, other than numbers and comparison of what is happening between countries, the other issue on which there is a lot of discussion, speculation, a lot of opinions being aired is how fast or how slow is the infection spreading, and when will it peak? And then the question that flows from that is, has lockdown helped in some manner controlling the peak? Now, the most important thing to remember is that lockdown will only slow down the spread of infection. It will not eradicate it. And there have been a whole range of estimates. Before lockdown, there was one estimate made by CDDP Washington, Dr. Ramanan Lakshminarayanan, who predicted at that stage that if nothing were to happen, this was before lockdown, that there would be, by July 2020, in India, 300 million infections and about 30 million cases of people actually registered and in hospital or under treatment. So that was one estimate that came out. During lockdown, the government's it's a very major institution within government, the Niti Aayog, actually predicted somewhat bizarrely that we would see our last case on 16th May, and that obviously has not happened. We see an increase in cases every day, even now. And the Niti Aayog again has come out with another figure, estimating slightly under 30 million cases by the 15th of August. So there are all these figures being bandied about. Can we see the next slide, please, Vinita? These figures are being bandied about, and basically what they are saying, and this is a graph prepared by the CDDP Washington, which makes a simple point, which I think is important to recognize, that the spread of the virus will always peak. All a lockdown will do is both push the peak into the future and perhaps reduce the level of the peak. Even the most intensive lockdown is still going to produce a fair number of infections, which will peak and fall. So this is something that we need to remember, because right now, today, for instance, lockdown is being steadily eased within India. The lockdown that began on 25th March. Today, we've had an announcement that domestic air travel will start next week. And there is interstate trains have been announced. The point to remember is this, that even if you're going to relax lockdown, the infection has gone nowhere, and that peak is still to come, and according to this graph, somewhere in July. So this is something we need to remember. Next slide, please, Vinita. Now, some important things about the lockdown. Certainly, it was one of the most severe of any country in the world. And the most important question to ask is, how have we used the time that we have gained? We have managed to control the spread of infection, and in so controlling the spread, have we done whatever then needed to be done? The question I've asked on slide 15, was India prepared with PPE, with testing facilities, with hospital beds? And I think we really have to, it seems more and more that while there was some preparation, there was also a lot of chaos. And no one really seemed to know what immediately needed to be done. Now, the most obvious thing to have done following lockdown was to identify those in our population who are most at risk. The elderly, the immunosuppressed, the diabetics, the hypertensives, the cancer survivors, people like this, who ought to have been identified, isolated, tested. It may not have been necessary to test large numbers of 25-year-olds, but this was not done. So testing, even where testing was done, even in the states where testing was better than in other states, it was completely random. So we may not really have been testing the people we ought to have been testing. The other issue that is really very important, which has attracted attention around the world, is what we have seen of migrants. Now, this is a much, much larger issue, and have a slide further on about this, but the short point here is that a very, very large number of India's labor actually work in what is called the informal or the unorganized sector. Many, mostly in the smaller and larger, in the larger towns and cities. And when lockdown happened, they were almost immediately put out of work. Most of these people probably also don't have regular housing, and probably live in camps and shanties of various sorts. So overnight, pretty much, there was no job, there was no shelter, there was no food, there was no income. And pretty much the only thing these people could do was go home, which more often than not is very far away, usually in the less developed states of Bihar, Jharkhand, Orissa. And since there was no transport, people began to walk. Now this, on any definition, this is an absolute calamity. And my friend Vikram Patel, professor at the Harvard School of Public Health, actually said on TV the whole lockdown was appallingly planned and executed. But nobody seemed to know what the hell was going on. That you had lockdown and you had almost immediately huge numbers of people who were unprotected. Now, the finance minister herself, at a meeting that she took to announce various measures the government is taking, put the number of migrants at 80 million. Now, 80 million is a very large number of people, and it's not very clear whether she meant that the entire 80 million were on the road, or the 80 million was the number of unorganized labor that could potentially be on the road. But very large numbers of people are, even as we speak, walking across India, and there has been a lot of confusion and very poor arrangements for their shelter on the way, their stay, their movement. So that is a very important aspect of what has happened in India. There's also the question of, this is linked to the earlier point I was making about the numbers of deaths. Let us also remember that this was someone wrote about this, that on the 5th of May, when India had 1,568 deaths for the same period over which lockdown had happened, we would have had 3,67,000 deaths of influenza. That there are huge numbers of people dying from various causes. So while COVID deaths are important and as far as possible should not happen, we should not also get carried away given the numbers of deaths that are in any case happening. One last point on this slide was this question of, for those of you who are interested in the legal and governance aspects of this, lockdown was imposed under the National Disaster Management Act, which is a central act in India's federal system. Public health and sanitation is entirely a state subject, and the Epidemic Diseases Act, which is could not be used, and a central act was used. There are political aspects to this. There's also the question of whether there are any civil liberties issues. So these issues will be continuously discussed. So the short point here is that while we've had a very severe lockdown, we've probably not used our time in the best possible way. Next slide, please, Anita. Yeah, this is just some data which I won't spend too much time on. There is dedicated COVID hospitals and beds. But the most important aspect of this slide really is testing. And are we doing enough testing? We've crossed 100,000 tests per day, but in India's context, that is probably not very much. And this varies. This is just a national figure. This varies enormously across states. Next slide, please, Nita. Yeah, now, there is another very important aspect of COVID and the lockdown. There have been enormous health impacts of the last few weeks, whether in the fall in universal immunization. India has 26 million babies born every year, which comes to somewhere over 70,000 babies a day, who ideally need to get 9 shots over the first 12 months. The universal immunization program, which is a massive, massive government program, that has taken a very severe hit. Because of lockdown, the frontline workers have not been able to attend to their duties. We will know exactly how serious this is when measles and diphtheria outbreaks happen later in the year. So that is something to keep in mind. Likewise, institutional deliveries, that is deliveries within institutions and not at home. This is something that we've pushed for the last 15 years. There's been, as per government statistics, a huge reduction, as also reduction in clinic attendance, acute cardiac events, etc., etc. Let us also remember that at any point of time, even prior to COVID, we have huge numbers of people with various conditions that need continuous medical attention, whether it is 70 million adults with mental illness or people at risk of malaria, and very, very importantly, tuberculosis, where not only have treatment schedules collapsed, there's also the problem that during lockdown, people with tuberculosis have been locked down with family and neighbors and people who are therefore at a much higher risk of infection. There have been, again, and these are official figures, increase in attempts at suicide, domestic violence, unwanted pregnancies, unavailability of family planning methods. All this is happening, which all those who are interested in public health aspects, these are things which will play out over a much longer time. And we will only know the full impact of all this in the months to come. Next slide, please, Nita. Yeah, this is what I was mentioning earlier. This is already on record: unintended pregnancies, unwanted childbirths, increase in intimate partner violence. And this is really coming out of government sources. So this is not speculation. This is not, provocative writing by the press. This is all stuff coming out of government. And as I said, we will see the impact of this. Women bear the brunt of the pandemic, as we've always known in a situation of illness, that it is, whether it is care of the person who is sick, whether it is responsibility for the person who is sick, inevitably it tends to be the women in the family, especially in the poorer families. So these are big issues. Next slide, please, Anita. Yeah, very quickly, few countries, I mentioned this earlier about how deaths per million have been much lower in India than elsewhere. But there are interesting things happening. I would in particular call attention to the Mexico-Colombia situation, where both countries were exactly at the same place around mid-March. But today's date, their situation is completely different. And this is attributed to the fact that in Colombia, there has been complete lockdown, whereas in Mexico, there has been partial lockdown, and they relied more on, people voluntarily adopting social distancing. But you can see a difference in the both in the number of confirmed cases and in the number of deaths. On the other hand, that everyone has been talking also about South Korea, which has pretty much gone through the whole cycle very quickly, very early, very effective testing, some number of deaths, but still what you might say under control. Then there is Sweden, which didn't have lockdown at all, which believed entirely on social distancing, and where the figures in terms of number of cases, number of deaths is significantly higher than in the other countries of Scandinavia. So as I said, this is all data that post-crisis people will have to look at and try and understand both how the virus has moved, and B, how each of these different responses has worked. Next slide, please, Anita. Now, in India, there has been, everyone has heard of Kerala. As I said, the first case was identified in Kerala on the 30th of January. And as of today, there have actually only been 4 deaths. Of the 3,303 deaths in India, only 4 have been in Kerala. And a lot of this is attributed to the fact that, to 2 facts really. One, that there is a functioning public health system and has been for many years. Secondly, they saw the warnings and got off the ground very quickly, hired 30,000 health workers very, very quickly, and very intensive testing and contact tracing. Kerala has a lot of global traffic with the Gulf. Kerala airports are very, very busy, but the government swung into action, was able to track everyone who was getting off a plane, test them, isolate them where necessary, treat them, and also concentrated on the more vulnerable sections of the population. So this is a very important lesson. It tells us something which I'd like to say a little more about later on, about the importance of having invested in a well-functioning public health system. This is where you see they would not have seen this effect at the time the investments were made, but the effect is being seen now. Next slide, please. Yeah, very quickly, as I said, for those who are interested in law, lockdown was imposed under the Disaster Management Act, not under the Epidemic Diseases Act. Other countries, the UK and Singapore, have enacted fresh legislation. This is an interesting question for those of you who are interested in public policy as to when and why do you need legislation? I mean, do you need legislation if you have effective executive action? Or are there situations where executive action does not work? You do need the force of law, but then if you introduce a law, would that law actually be, would it be justiciable? Would it work in courts? Who would take it to court? What would the court do? Even if the court gave a ruling, would it actually result in any benefit to whoever it is who has taken the matter to court? So these are, as I said, interesting policy questions. Next slide, please. Yeah, now this is, there has been, as I said earlier when talking about migrants, with huge numbers of factories, manufacturing industry, everything being brought to a halt, there obviously has been tremendous impact on the economy itself. We can see some of the figures here. The Center for the Monitoring of the Indian Economy, CMIE, which is not government, but which is a very well-respected data gathering analysis organization, estimated 24% unemployment on the 16th of May. Micro, small and medium enterprises which have closed down need revival. Labor has gone away. When will they come back? Will they come back? My slide says trains and flights have been cancelled. As I said just today, some announcements have been made. Electricity generation in the 1 week of March where there was lockdown came down by, I think it said 16%. We don't really know what has happened in April, which is entirely under lockdown. So the consequences of all this is not just for the economy, but also for the people who make up this economy. If manufacturing industry has taken such a severe beating, Where and how are incomes to be generated? Where and how are people going to be able to get back to investing in themselves and their families and in their care, in their health care? An issue which I have not mentioned here is also to do with schooling. Huge number of schools across the country. It's all very well to say children can learn online. This is not an option for thousands of children in government schools, corporation schools in India, who do not have the option of learning online. So if schools are closed, that's another big hole. So there are these sorts of conditions, all of which are contributing to, I mean, I don't think anyone has used the word recession as yet, but it is certainly headed in that direction. Next slide, please. Yeah, now, so what happens next? Some of you would have seen the World Health Assembly resolution of yesterday. Given WHO resolutions, this actually asks for, in the best diplomatic language, for a serious inquiry into why and how we have found ourselves in this position. But the three big questions to ask, first of all, is the epidemic under control? And I think the fair answer to that is not quite. Not quite. We still see daily increases in the number of cases that are being detected. There is a daily increase in the numbers of deaths per day. So is the epidemic under control? No, and I don't think we can say it is under control till we have passed the peak, which, as we saw earlier, is a little into the future. Can the health system cope with the possible resurgence of cases? Maybe, because we've had district hospitals are coping at this point of time, but they are coping at the cost of the health care and treatment of non-COVID patients. Persons who do not have COVID but have other conditions that need hospitalization are being turned out because these beds and facilities are being reserved for possible COVID cases. A very important point to listen here is, in India as in other countries, this whole question of public sector versus private sector in healthcare. And one lesson has come through very strongly, which is that the burden of COVID-19 in India has been borne by the public sector. Private sector may have helped, but certainly has not pulled its weight in any significant way. And even where private hospitals have reserved beds and such like, these are still only available on payment and are therefore not available to a very large number of Indians. So can the health system cope? Yes, but it is a crumbling system and it needs a lot of investment if it is to seriously cope not just with this crisis, but with crises that are likely to happen in the future. Is there an ability to track and trace new cases? Yes, and if you look at the testing figures, this is happening, but I would still say that it is random testing. It would have been more appropriate if persons most at risk had been identified and tested. As I said, the elderly, the people with comorbid conditions. Just testing people on the road, while it serves a purpose, is not the best use of our testing abilities. So that is certainly still a problem. Next slide, please. And then this is my last slide, and I just call them larger issues because the virus will pass. The virus will pass at a cost. Many lives that should not have been lost would have been lost. A lot of damage would have been done to persons with other health conditions, a lot of damage done to the economy, a lot of damage done to functioning systems as we know them. But there have been some other issues that have come up to which I would just like to call attention before we end, which is that, I mean, all of you know India. India is, and no one likes saying this, But we are a hugely divided country, we're a hugely divided society, and the difference between us and them has come out more starkly than we normally see in India. And I've said they're relatively better off, have survived lockdown. Now, I mean, people like me, people like us have survived lockdown. We will survive lockdown. Working from home is a possibility. But this is not so for many, many millions. And this has been brought home to us, what I was saying earlier about migrants, in a very cruel way. COVID-19 management has not, unfortunately, been treated as a public health matter. It's a law and order issue. All the focus is on police at state borders trying to prevent people from entering the state. And these are people coming on foot. Police pushing people back and police arresting people. Now, this is, as I said, this is not a police matter. This is a welfare issue, and there is no real sense that we are looking at this as a welfare issue. Stigmatization of COVID-19 patients and their doctors, caregivers, unfortunately, also true. India's cities have not shown themselves well. Chennai, where I live, there are reports in the papers virtually every day about doctors who are working in hospitals treating COVID patients being prevented from coming home, persons with COVID who have been diagnosed with COVID being forced to leave their homes. This is extremely unfortunate. Even more unfortunate is this whole question of and there's no simple way of saying this. The communalization of the spread of infection. Infection spreads in many ways. An unfortunate incident in New Delhi where it was a gathering of Muslim persons belonging to a subsect of Islam. Many people there had symptoms. Many people developed cases. They infected other people. Unfortunate, misguided, totally stupid. But the fact is, it was not the only such case. And unfortunately, India's press highlighted this endlessly, making it appear in some manner that this is somehow, I mean, I hate to say this, but this was somehow kind of a Muslim disease. This is going to have consequences well beyond COVID-19. The neglect of women's concerns is what I mentioned earlier. My last question is, I mean, this is the biggest question of all. As I said, COVID will pass, but will we see greater investment in the public healthcare system? Alma-Ata in 1978 called for 3% of the GDP investment in the healthcare system. India has never crossed 1.1, and we're even lower than that right now. And this includes budgetary investments both by the government of India and by the states. And this is, have we learned from this? Have the states learned that despite their problems, we will need to find the money to strengthen district hospitals, primary health centers. They will have to find the money to set up government and medical and nursing colleges. They will have to find the money to equip existing government facilities better. They will have to find the money to ensure that every government facility is fully stocked with drugs and disposables at all times. I mean, as the government of India, they realized that they will have to support the states in doing this. The whole focus of the government of India's attention in the last few years has been on a private insurance-driven, hospital-based treatment. It's a scheme called Ayushman Bharat, and no emphasis on the fact that government facilities need to be strengthened. So this is a question we have to wait and watch. We may not see anything in the next few months when we are still fighting the crisis. But as I said, when the dust is settled, this is a question we have to see, because that really would be India's best response. And if we don't face that question, don't understand that more money needs to be invested, then there is really no response at all. And there is every likelihood that we will find ourselves in this sort of situation the next time there is a pandemic. So that's really where we are, and that's what I wanted to say today. And I'll be very glad to take any questions that anyone has to ask. Thank you.
Thanks very much, Keshav, for a fantastic presentation. I'm sure that there's virtual applause that we can't hear. So in this Q&A session, just mindful of time, I'm going to try to weave in some of the. We had two questions that we were going to sort of discuss during this Q&A session, and some of the questions from the audience members are along the same lines. So I'm going to try, in the interest of time, to weave some of those questions into what we are going to discuss. So the first question was something that Vinita highlighted, which was the response given by Kerala, and this is something that you alluded to as well. If we sort of look at Kerala and its next door neighbor, Tamil Nadu, there was massive variation. Their next door neighbors, Kerala, as you said, had 4 deaths. Tamil Nadu had about 100, a little less than 100. Kerala had cases in the hundreds. Tamil Nadu had almost 13,000, 14,000 cases. So I guess weaving in one of the questions from Vinod Srihari into this, what sources of information would you recommend to track this pandemic in India? And so that, I guess, sort of relates to what Kerala did versus what some of the other states did. And maybe we can use Kerala versus Tamil Nadu as a small case study just in this discussion. And then from the Right Honourable Patricia Hewitt, did any other states come close to Kerala's example and the success that it had in actually controlling this? And then I guess one nuanced thing that I would add into this is, can we trust the data? Because are India's sort of data collection systems robust enough to actually give us an accurate picture of what's actually going on the ground? And could there actually be greater variation and higher levels of death than's actually been recorded?
Anant, thank you. Very good question. Let me take the third question first. I said earlier on, I think that when the dust settles, we will have to go back and look at all the data all over again. Right now, all the writing that is coming out is either in the press or on the social media. And so it's possible that that is something we will of course need to, everything will need to be checked when the crisis has passed. Now, have other states looked at Kerala? Not really to my knowledge, but I'll tell you, I think the reason for that is also clear. To my understanding, the two big strengths that Kerala had in this, one is they were very good on testing. They were very good in tracking people as soon as they arrived. And as I said, they had huge numbers of people coming in from abroad. They were very good on testing, tracking, isolating, quarantine, and treatment. Much quicker off the ground than many other states. Secondly, they do have a functioning public health system. And that is something which other states cannot replicate overnight. Tamil Nadu also likewise has a good and strong public health system, but I suspect here testing was not begun in time. It was also not done particularly efficiently, and that probably accounts for, in these sorts of things where the viruses, where cases are growing exponentially, loss of time has a calamitous effect. Having said this, let me say that within India, there have been some critical writing on Kerala. There was one piece which made the point that COVID-19 is spreading in the cities. COVID-19 is spreading where there are populations packed into tiny spaces. Kerala doesn't really have any cities. It's just a collection of towns spread along the entire coast. And when you have a lesser density of population, obviously you're going to have a lesser spread of the infection. I don't know if this is true, but this argument has been made. And the other argument that has been made is that, and this is linked, Anant, to your question about data, that Kerala has just been very lucky and the people have not died, and also suggesting that some data regarding deaths may have been concealed. But I don't believe that is so. It is not easy, certainly, to conceal a COVID death. I think it would be very unfair to the Kerala system to say that that their relative success is because they are hiding data. But as I said, let's wait for the crisis to pass, and maybe then we'll have a better understanding once we look at hard hospital data across both states, other states, to get a sense of what has worked.
Great, thanks very much, Keshav. Now, this next set of questions, again, I'm going to try to weave in some of the questions from the audience as well, just in the interest of time. In the UK, what we're seeing is reports about 3 million people in the country saying that they went hungry in the first weeks of COVID, the COVID lockdown, because of lack of access and also lack of funding. We're seeing a spike in domestic abuse cases. We're seeing a spike in unemployment. We're nearly at 1 million right now. We're seeing a spike in alcohol abuse. And I guess this sort of touches on some of the points that you made. We're also seeing an increase in the inequalities around education. So some of the children who were in poorer served areas, they're actually falling behind even further relative to some of the more affluent areas in the UK. Now, this is happening in the UK context, and I think this sort of alludes to some of the points that you made in your presentation. I think it's a truism that we need to invest more in public services and public health. And obviously there are sort of gloom and doom scenarios with predictions of disaster, which I don't think are unfounded. But could we use this as an opportunity to almost create an alternative future? So as per Premila's early question, for these internal migrants in Kerala, for example, could we create better support structures for them? As Sophie has mentioned, can we elaborate or look at how we can mitigate some of the negative impacts of the school closures? As Safa has mentioned, can we look at alternatives to strengthen some of the basic services for water, hygiene, nutrition, housing, etc.? And some of the stimulus packages that have been proposed by the current government, are they sufficient? I know this is sort of a long rambling question, but these different determinants, to sum up the sort of long rambling question, can we create an alternative future? There will obviously be heterogeneity between the multiple states in India, but at a federal and state level, can we use this as an opportunity to correct some of the existing imbalances? Big question, but your thoughts?
No, Anant, the answer to all those questions is yes. It cannot but be yes. Yes, this can be done. But it will take not just the availability of money, but the political and the executive will to want to do so. Now, some of you may have followed, following the migrant crisis, there has been some move towards what they call reform in labor law, but which effectively takes away whatever protections workers have now. So there is a response, but not the kind of response. What we would like is a law which said that if there was something like a pandemic happening, then it is the responsibility of the employer to take care of workers, even if they are categorized as informal labor or part of the unorganized sector. But what we are seeing is an attempt to do away with those labor laws that have some modicum of protection for labor. So likewise, can something be done for the huge cohort of school children whose the education has been completely stopped, as it were? It will probably be 6-9 months by the time they are able to resume proper schooling. Yes, obviously, yes, it can be done. Technology can help us. There are enough people who know about school teaching and about how children learn. But it takes, as I said, not just money, but will. And, you know, we should not go back to business as usual after the crisis has passed. India works well in crises. We are actually not bad on handling disasters. We're actually not bad on doing mass programs like general elections. But there's a tendency also, when a crisis has passed, for things just to go back to where they were before. So there are clearly all these things that need to be done. But as I said, it is both political and executive will that will make them happen.
I mean, on that point, I know this is sort of a derogatory framing, but the Bimaru states, for example, in India, do you think there is a potential that there might be an increase in the inequality between states post-crisis? And do you have any thoughts on what could be done
there's
to
something
reduce this?
We need to know the labor that is currently moving back to the poorer states. No one seems to know whether, when their employment opportunities open up again in the bigger cities, in Chennai, in Mumbai, in Bangalore, in Hyderabad, whether they will come back. And having had a terrible experience, or would they come back at all? If they didn't come back, what would they do in their homes, in their home states? Now, we don't seem to know this right now. Clearly, there aren't enough employment opportunities in their home states. These are not going to develop overnight, but we need to see where this goes. There's again some interesting things have happened. All the harvesting in the richly agricultural state of Punjab is done by laborers from Bihar, who actually went back after lockdown was declared. But Punjab has somehow managed to harvest the Rabi crop, and in fact, their what they call procurement of food grains by government has actually been higher in 2020 than it was in 2019. But right now, as we speak, there is no labor available for the Kharif plantation. So these are all questions, Anant, that are out there. And a lot depends on how labor will move. Now, let's also remember that we just say migrants as though but these are people who have really very few resources. And they are probably currently unwell, sick, hungry, no money. And we have to really wait and see where they move, if they move, whether the governments of Bihar and Jharkhand and Orissa will be able to create employment opportunities, which they have not been able to do till now. So these questions are out there. It is, we'll have to wait and watch. You can be sure that manufacturing industry in Chennai and Hyderabad and Bangalore will try and tempt them back because they need to function. But we have to see what will they offer, how quickly can they offer it. There have also been some employers whose conduct has been exemplary. You know, in the Pune side, I was seeing a program yesterday. Dr. Naushad Forbes was speaking. There have been many units which have retained their labor by giving them reduced wages, but promising them help till the crisis has passed. But those are actually only very few.
Thanks very much, Keshav. So I'm going to turn to formally to the audience questions now. So I'm going to try to weave in two questions, one from Melly and then the other from Anonymous on policies and the system as a whole. So Melly's question is, I'm just going to sum up, and I've asked her in the chat whether it's okay for me to sum up as follows. Should private hospitals with their infrastructure be required to modify their practices in the face of a crisis? That's one. And then Anonymous's, this person's question is around vaccines and supply chains and logistics. So again, sort of a question around how do we actually mobilize? Yeah.
The answer to question one is yes. In fact, people have been talking about nationalization of private hospitals. I mean, that may not be necessary, but government does have the powers under existing law to requisition beds, for instance, which the Mumbai Corporation has done, and some other states may also have done it in bits. So certainly, yes, I think the legislation is not needed. Executive orders would be enough for requisitioning of beds and space and facilities in private hospitals at a time of crisis. This is certainly something that can and should be done. Now, the vaccine question is very, very important. Now, India, we have a we produce, I think, over 60% of basic vaccine material around the world. But India's universal immunization rate is still, national figure is still 62%. So we are producing vaccine material. We are not able to immunize all our children. So this is in itself a bad situation. People are talking about the Oxford group, which is closest, I believe, to developing a vaccine. And I keep hearing that October is somehow when this is to become available. The Serum Institute in Pune, which is India's one, not government, but it's an extremely advanced high-tech facility, is supposed to be in some kind of collaboration, and clinical trials will start. No, clearly we need to, the vaccine question is very important, but I don't seem to have a sense of how long this will take. Dr. Soumya Swaminathan, chief scientist of WHO, last week said something about 3 to 5 years. Now, so we need to talk to virologists and people like that, but that India is in a position to respond to developing vaccines commercially is in no doubt. We can do it.
Thanks, Keshav. So I'm going to try to batch again a few questions together. So this is around data and the response. So from Nermeen and Dilip, is this question around learning from the data in real time and responding to the data. And Dilip asks if you're able to state the sites and the references for the accurate data. And then finally, so we're looking at, where is the accurate data firstly? Secondly, was it possible to respond in real time? And again, I'm pretty sure that there was probably heterogeneity between the different states. And then finally, from Anonymous, is this question around the role of experts in this process. When the models were created, when this data was looked at, was it sort of given that the experts were listened to, or were they silenced? What was the response to the experts in this?
I think that's called a leading question. But the first point is the source of data. The best source of data in India is IDSP, the Infectious Diseases Surveillance Program, which is based out of the NCDC, the National Center for Disease Control in Delhi. Now, interestingly, IDSP in the first week of February 2020 put out publicly on their website data about COVID-19 cases they found in 3 places in the country. Very mysteriously, the IDSP website has collapsed after that, and they've published nothing since. But IDSP is the most reliable authorized source for collection of data regarding the spread of disease. And I expect that at some point they will come back to life because they do have the data. And I'm sure that even though they are not publishing their data in these months, they are collecting it. So that would be possibly the best source of data. Hospital data across the states will also be accurate. There will be, I'll tell you where the problem will be. The problem will be in many COVID deaths not being reported as COVID deaths. That has happened, I believe. But hospital data in itself would be reasonably accurate and should be looked at very carefully once the crisis. We can't expect anyone to start looking at it now. what comes out now is data coming out without analysis. But the analysis will probably need to be done very carefully by the people qualified to do it, by epidemiologists and biostatisticians and people like that, and not by just any random physician, or even worse, by random journalists and people who interpret the data any way they want.
Thanks very much, Keshav. We have no more open questions. So we're about 5 minutes to the close. So can I suggest, Keshav, you end with any sort of final comment on your hopes and fears for the future post-COVID, and then we can hand over to Vinita to close the session and talk about future webinars.
Well, thank you, Anant. Thank you. I've enjoyed the session. I appreciated the questions you've asked. No, my hopes, I said them clearly. I mean, one can, over the longer term, I hope government learns that you do need to invest. In the medium term, I do hope that this migrant situation is attended to. It really is a human catastrophe. Of people have compared it to the worst thing that has happened since partition, this movement of men and women across India. And what does this mean? How are we able to, apart from anything else, I mean, restore these people's faith that India is a country that will care for them and protect them? I think that is going to, and this is not just political. This is, I mean, everyone needs to be involved in this process of, I mean, a calamity of this order, which was completely not foreseen, but which has hit us. And in the immediate short run, I mean, what can I hope for? That since clearly it is clear that lockdown is being progressively lifted, but that people observe sensible precautions. India is, as all of you know, we are not just densely populated. Our cities are overcrowded, teeming places. Very hard to maintain physical distancing in the Indian kind of context. But I think individuals and communities and neighborhoods need to learn this. And this, in the immediate short term, this is necessary. And, you know, many things about the way we live our lives need to change. You know, social gatherings are very frequent in India. People just meeting for one purpose or the other, for social purposes, for religious purposes, for whatever. All these things will need to change. All these things will need to stop. Whether we've learned enough as individuals to be able to do this, I think only time will tell. Thank you. Vinita, I think it's your turn.
Vinita, you're on mute.
Vinita, we can't hear you. You're not speaking either.
She is, but she's on mute. So,
Yes, okay.
There you are. Cool.
Yes. Okay. Thank you for this very informative session, and Anant for stitching together these questions so well, and for the audience for their questions. Before we close, I just would like to invite you all to our other events lined up in the coming weeks. So next week we have another event on COVID and malnutrition among adults and children in India, and it will feature Anant as well and Sahil Shah. So please do drop in an email onto our email ID oicst@some.ox.ac.uk, and in case you would like to attend the event. And so thank you very much for joining once again.